The thyroid gland, located on the anterior surface of the thyroid cartilage in the neck, secretes the hormones triiodothyronine, or T3, and tetraiodothyronine, or T4. You might not realize it, but these hormones affect almost every organ in the body, helping with bone maturation and growth, brain maturation, regulation of the basal metabolic rate. Yep, T3 and T4 are always there, sneaking around in the background. A secret criminal organization known only as Grave. Your mission? Take down its villainous leader, Dr. Storm. We'll go over a little bit of thyroid physiology now, and later we'll show where each thyroid drug fits into the whole thyroid hormone metabolic pathway. The thyroid hormones, T3 and T4, contain iodine as an essential part of the molecule. Iodine in its anionic form is called iodide, which enters the body when ingested with food, water, and medications. Once in the bloodstream, iodide enters the thyroid gland via the thyroid follicular cells. The inner workings of the thyroid follicular cells will be depicted here, inside Dr. Storm's concealed and undeniably evil follicular layer, located behind the bar. Iodide uptake by the thyroid is an energy-dependent process that utilizes a sodium iodide symporter located on the basement membrane of the thyroid follicular cells. In other words, to get iodine into the thyroid, it needs to be transported along with sodium. At Sketchy, sodium is represented by a recurring salty sodium peanuts. Yep, just a harmless box of peanuts. Or is it? As sodium rushes down its concentration gradient, it smuggles in some iodide with it and concentrates it inside the follicular layer. New materials for the underground manufacturing of iodine dirty bombs, I'm sure. After getting inside the follicular cell, the iodide is then transported across the apical membrane. This is represented at the back of the layer, where a covert iodide packaging and transport operation is already underway. The big opening inside that illegal transport truck should remind you of the lumen of the thyroid follicle, where iodide is stored. It's stored in a special form, however. First, it must be oxidized by an enzyme that sits on the apical surface of the follicular cell, thyroid peroxidase, or TPO. We've included the letters TPO on the briefcase of this henchman here, responsible for the transport of the iodide. TPO facilitates the processing of iodide in a few ways. First, it oxidizes the iodide to iodine. At Sketchy, we often represent oxidation reactions with rusty, oxidized metal, incorporated here on the rust-covered delivery truck. Once in its oxidized form, iodine then rapidly latches onto tyrosine residues that are located on the molecule thyroglobulin. Tyrosine residues are symbolized, as always, by our recurring tyrosine tires. Also, you see that fake logo they've painted on the side of their covert transport vehicle? Pretty sneaky. Thyroid globule is really thyroglobulin. It's an organic molecule that hangs out in the follicular lumen, ready to accept any iodine ions that need storage. When iodine binds, this process is called organification. The last job of TPO is to couple the iodinated tyrosine residues together, and that's why we've drawn 2 tires on the truck instead of just 1. A diiodo and a monoiodo tyrosine coupled together gives you T3, while 2 diiodo tyrosines coupled together gives you T4. When thyroid hormone is ready to be released, the follicular cells engulf these thyroglobulin storage molecules, pulling them in from the lumen. And once they're back in the cytoplasm of the layer, the thyroid hormones tetraiodothyronine, or T4, and triiodothyronine, or T3, are removed from the thyroglobulin molecule. So we've got our final products, T3 and T4. T4 is represented by the iodine bombs set to a 4-minute timer. This is the less potent form of thyroid hormone, as indicated by the green LCD numbers assuring us that the bomb has not been activated yet. The more potent form, T3, is represented by the activated bomb, which has started its countdown sequence. T3 is about 3 to 4 times more potent than T4. It's okay, just calm down. Just cut the red wire. It's always the red one, or the blue one. Luckily, most of the thyroid hormone produced by the thyroid gland is in the T4 form, which is why we can see mostly T4 timers here in the layer. To find out where most of the T4 is activated, we need to head out into the circulation. T4 is deiodinated to T3 at peripheral tissue sites by the enzyme 5' deiodinase. This enzyme is embodied by this evil henchman here, who has triggered the countdown on the T4 timers. There's no turning back now. Once activated, T3 enters the nucleus, where it binds to an intranuclear thyroid hormone receptor, leading to an increased transcription of several hormone-responsive genes. One of the effects of thyroid hormone is to increase the sensitivity of peripheral tissues to sympathetic stimulation. To do this, T3 actually causes increased transcription of beta-adrenergic receptors, which increases the body's sensitivity to circulating catecholamines, such as norepinephrine. Here, circulating catecholamines will be represented by Dr. Storm's fish tank, full of circulating catfish. You see that henchman there, who sadly was recently, how can I put this, let go from the Enterprise? He sure looks more sensitive to those catecholamines, if you know what I mean. Many of the symptoms of hyperthyroidism resemble sympathetic nervous system overactivity, including tachycardia, palpitations, insomnia, anxiety, tremor, heat intolerance, and weight loss. Let that big, red, thyroid-shaped bow tie on this nervous henchman here remind you of hyperthyroidism and its associated hypermetabolic and hyperadrenergic symptoms. We won't go into too much detail here, but the most common cause of hyperthyroidism is Graves' disease, an autoimmune disease where lymphocytes secrete a TSH receptor-stimulating antibody that activates the crap out of the thyroid. Other causes include toxic adenoma, toxic multinodular goiter, and thyroiditis. Remember that Graves' disease, specifically, can also present with Graves' ophthalmopathy, a condition that involves an increased volume of both the extraocular muscles and retroorbital connective tissue due to cellular proliferation, inflammation, and the accumulation of hydrophilic glycosaminoglycans. In your patient, this will show up as exophthalmos, kind of like the bulging infrared goggles worn by our next henchman here, sneaking out of the bar. All right. Now that we've outlined the pathway of thyroid hormone production and action, I want to show you a few different points of attack we can use to take down this whole operation. Let's begin with the most direct and effective method, destroying the layer from the inside. In the US, most patients with hyperthyroidism due to Graves' disease are treated with ablating doses of radioactive iodine. These radioactive atoms become concentrated inside the follicular cells by traveling through the same sodium iodide symporter as before. But this time, their plan is foiled. The smuggled iodide product has been replaced by a much more dangerous radioactive version that destroys all it touches. With all this damage to the thyroid gland, it's not hard to imagine that radioactive iodide treatment can lead to hypothyroidism. At Sketchy, our recurring symbol for hypothyroidism is an ineffective undone bow tie, like this one here, burned by that toxic iodine. This occurs in 80% of patients, so make sure to monitor serum T4 and TSH levels regularly. Conversely, there's also a small risk of radiation thyroiditis from radioiodine treatment. This causes severe thyroid pain and an exacerbation of hyperthyroidism, as depicted here by the sweating, palpitations, and tremors felt by the henchman as he succumbs to the radiation. Also, for unknown reasons, radioiodine therapy can even cause a transient exacerbation of Graves' ophthalmopathy, hence the bulging infrared goggles. In fact, radioiodine is relatively contraindicated in patients with severe pre-existing ophthalmopathy. Patients who are more susceptible to the effects of hyperthyroidism, including older patients and those with severe thyroid toxicosis, may be pre-treated with a thionamide drug to deplete hormone stores before ablating the gland. That way, when the layer is destroyed, you don't get too much thyroid hormone leaking out and causing systemic symptoms. So it's time to introduce our secret thionamide agents. Their mission? To knock out thyroid hormone production from the inside. The thionamides include propylthiouracil and methimazole. They treat hyperthyroidism by directly inhibiting thyroid peroxidase, which, if you recall, is the enzyme responsible for oxidizing iodide so that iodine can undergo organification and storage. Propylthiouracil, abbreviated PTU, is embodied by our first secret agent, as he whips out his concealed weapon and fires at the TPO transporter. Patew, patew, patew! The other thionamide, methimazole, is represented by this chalkboard filled with evil math equations. Taking over the world involves lots of trigonometry, apparently. Notice that this methimazole math board is being maneuvered by our spy to strike down yet another TPO transporter. Methimazole is actually 10 times more potent than PTU and is the drug of choice in adults and children. See that, kids? Math is cool. Remember, inhibiting thyroid peroxidase reduces iodine organification and coupling of the iodotyroxine molecules. As mentioned previously, thionamides can be used before destroying the gland with radioiodine treatment to deplete thyroid hormone stores. Thionamides can also be used alone for patients with mild hyperthyroidism and small glands. Our PTU agent has other specialized training as well. It turns out that he can inhibit the enzyme 5'-deiodinase located in peripheral cells. You know, the enzyme responsible for triggering T4 into active T3. You look quite disarming today. Time to diffuse the situation. Delivery could use some work. Unlike PTU, methimazole does not inhibit the peripheral conversion of T4. Methimazole only exerts its effects inside the evil follicular layer. All right, since we're out in the peripheral circulation, let's take a look at some other ways we can combat the systemic effects of thyroid hormone. Recall that thyroid hormones increase the sensitivity of many organs to the effect of catecholamines. This was depicted by all those circulating catfish. A beta blocker, then, can come in handy. By blocking beta-adrenergic receptors, you can reduce the patient's hyperadrenergic symptoms, like palpitations, tachycardia, tremulousness, anxiety, and heat intolerance. The recurring sketchy symbol for beta-1 adrenergic activation is a rousing beta-1 bugle. Beta blockers, on the other hand, are muted bugles, or in this case, a pair of concealed bugle guns carried by our spy here, each with a silencer attached. Patoo, patoo, patoo. Sorry. While one of the silenced bugle guns is pointed at the catecholamines to prevent adrenergic symptoms, the other is pointed at the henchmen triggering the T4 bombs. Yep, beta blockers also inhibit 5'-deiodinase and the peripheral conversion of T4 into more potent T3. A beta blocker should be started in most patients as soon as the diagnosis of hyperthyroidism is made. There's one more secret agent on this mission who specializes in preventing the peripheral conversion of T4 to T3, and that's glucocorticoids. As always, glucocorticoids are symbolized by an eerie moon face, reminiscent of the moon faces that can occur with glucocorticoid over-administration and Cushing's syndrome. In this scene, the moon face is incorporated into the coasters our spy has ingeniously turned into super secret spinny ninja Death Stars to strike down the T4 triggering henchmen. Although they're less effective at controlling the systemic symptoms of hyperthyroidism compared to beta blockers, they do have a second function, particularly helpful in Graves' disease. The anti-inflammatory effects of glucocorticoids are useful in treating Graves' ophthalmopathy. Notice the second line of those spinning death coasters, knocking those exophthalmic goggles right off the escaping henchman's face. High-dose glucocorticoids decrease the severity of inflammation and decrease extraocular volume. Glucocorticoids are also used to prevent worsening ophthalmopathy induced by radioiodine treatment. Remember, PTU and methimazole decrease thyroid hormone production, but they do not affect the antibodies causing the ophthalmopathy seen in Graves' disease. For that, you need glucocorticoids. All right, our mission is almost complete. Their final objective is to take down the head of the whole operation, Dr. Storm himself. See that ridiculously oversized thyroid bow tie? That only a megalomaniac would wear in public? That will be our symbol for thyroid storm. Thyroid storm, or thyrotoxic crisis, is a sudden acute exacerbation of all the hypermetabolic and hyperadrenergic symptoms of thyroid toxicosis, presenting as a life-threatening syndrome. This can occur with long-standing, untreated hyperthyroidism, or after an acute event such as surgery, trauma, or infection. Immediate steps must be taken to combat this acute hyperadrenergic state. There are 3 goals here. First, gotta block the sympathetic effect on target organs. That means beta blockers to shoot down those catecholamine catfish. Second, gotta block thyroid hormone synthesis, so send in PTU to take out that TPO transporter. Patoo, patoo, patoo! PTU is preferred over methimazole in this case because it also has the secondary effect of blocking peripheral conversion of T4 to T3. Which brings us to the final goal of treatment. Block that peripheral conversion. Beta blockers, PTU, and glucocorticoids can all help with this. Dr. Storm has been foiled yet again. You know what, though? A life of spying, womanizing, and drinking, and high fashion really takes a toll on the body. And likewise, these drugs do have their side effects. PTU has a risk of severe hepatotoxicity and liver failure, which is represented here by this liver-shaped beaker getting broken in the melee. Because of this risk, PTU use is limited. It's mainly helpful for patients during the first trimester of pregnancy, thyroid storm, and in those experiencing severe reactions to methimazole. PTU has numerous other side effects as well. The most common is a maculopapular pruritic rash, as evoked by these splashing lab chemicals. Both thionamides, PTU and methimazole, can cause agranulocytosis. This is measured as an absolute neutrophil count less than 500. See that sand timer in the back? Someone has triggered the self-destruct countdown. Those granules are running out fast. Time to move out, agents. So remember, on the test, when your patient with a history of Graves' disease treatment presents with a fever, sore throat, ulcerations, and other signs of infection, stop the antithyroid drugs and get a white blood cell count. Although rare, PTU and methimazole can also cause severe bone marrow suppression and aplastic anemia, represented here by a big pile of plastic bone chew toys. Wait a minute. Oversized chew toys? You know what that means. An oversized guard dog. Yep. Dr. Storm and his cronies keep a ferocious guard wolf around for moments like these. A wolf is our recurring sketchy symbol for drug-induced lupus, a rare side effect of the thionamides. PTU specifically can cause an ANCA-associated vasculitis syndrome, hence the red inflamed vascular leash. In fact, these ANCA antibodies develop in about 50% of patients taking PTU. Most patients are asymptomatic, but some develop arthralgias and glomerulonephritis. Methimazole is considered a first trimester teratogen, and that's why we've included our recurring teratogenic tarantula there on the methimazole math chalkboard. You know, sometimes I feel like these secret agents use methods that are a little too extreme. I mean, she's getting bashed right on that baby bump. Kind of uncalled for. To treat hyperthyroidism in the first trimester of pregnancy, PTU is used instead. All right, all this talk about hyperthyroidism. What about hypothyroidism? It's a syndrome resulting from a deficiency of thyroid hormone and is manifested largely by a reversible slowing down of all body functions. The symptoms of hypothyroid include dry, brittle hair, lethargy, fatigue, weakness, decreased BMR, all embodied by the bartender here. That brittle, unkempt hair, packing on a few pounds because of that reduced BMR. We've even included a glass of ice cubes to remind you of cold intolerance. The most common cause of hypothyroidism in the U.S. is Hashimoto's thyroiditis, an immunological disorder in genetically predisposed individuals. Myxedema coma is an end state of untreated hypothyroidism, so think of him as our hypothyroid mixologist. Myxedema coma is associated with progressive weakness, stupor, hypothermia, hypoventilation, hypoglycemia, hyponatremia, and eventually death. Treat it by giving the patient thyroid hormone. Sounds logical to me. Treatment is in the form of IV levothyroxine, a synthetic form of T4. Remember, T4 is converted to T3 at peripheral tissues, so levothyroxine administration produces both hormones in the body. As expected, exogenous levothyroxine administration can produce side effects that mirror hyperthyroid symptoms. Wait a minute, that's not T4, that's C4. Take cover! Okay, this is getting a little out of hand. I get confused about which secret agent is which, all this flip-flopping. Is that guy still a bad guy? It's murky. Remember that iodide uptake by the thyroid is an energy-dependent process. In other words, it takes advantage of sodium diffusion to carry iodide ions against their concentration gradient and into the cell. Anions such as perchlorate, pertechnetate, and thiocyanate, and really just any iodide isotopes, can completely inhibit the basolateral sodium iodide transporter. Anions such as perchlorate, pertechnetate, and thiocyanate, and really just any iodide isotopes, can competitively inhibit the basolateral sodium iodide transporter. Just think of this anion spy tricking the delivery man and sneaking his way into the follicular layer. These ions compete against iodide for entry into the gland, resulting in a reduction of iodide uptake by the thyroid follicular cells. Accidental radioactive iodine exposure, for example, can be treated with potassium iodide to outcompete the radioactive iodide. That way, you can prevent radiation-induced hypothyroidism or even thyroid carcinoma. In summary, when treating hyperthyroidism, think about which part of the thyroid hormone pathway you're trying to prevent. Systemic effects at peripheral adrenergic receptors? Throw on a beta blocker. Exophthalmos due to Graves' ophthalmopathy? Try a secret ninja star surprise attack with a glucocorticoid. What if you want to stop thyroid production inside the gland itself? For that, take a look inside the follicular layer. You can destroy it from the inside with radioactive iodine, or prevent thyroid hormone production and storage by inhibiting TPO. That's the job of PTU and methimazole. And lastly, what about peripheral conversion from T4 to T3? Beta blockers, PTU, and glucocorticoids will all prevent this, so all three are useful during a thyroid storm. So, which agent do you think played the part best? Come on, everyone has a favorite. And in my opinion, you can't beat the original. That's a Smith & Wesson, and you've had your six. Smith & Wesson. Smith. All right, I'm done.